I'd like to call on Dr. Rachel Climie from the Baker Heart and Diabetes Institute, who will tell us about lifestyle factors and hypertension. Rachel?
All right, so I've just shared my screen. Can you see that, Hamdi?
Yes, we can, but do you want to put it into presenter view?
Sorry, 2 seconds. How's that? Is that better?
Yep, that's fantastic. Thank you.
Okay, great. Okay, thank you, Hamdi, for that introduction. So I've been given the topic of lifestyle factors and hypertension to talk about, but I've slightly modified this and we'll actually discuss lifestyle modification for firstly the prevention of hypertension, and then secondly for managing hypertension once someone does have overt hypertension. So as we've heard over the last couple of days, high blood pressure poses a significant health burden. We know that elevated blood pressure is the single biggest risk factor for the global burden of disease and mortality. And in 2017, 10 million deaths were attributed to elevated blood pressure. We know that elevated blood pressure is associated with a host of other conditions such as myocardial infarction, stroke, and heart failure, and so on. And added to this, high blood pressure poses a significant economic burden. So in Australia in 2017, 26% of adults had hypertension. And this actually resulted in a loss of GDP of approximately 137 billion Australian dollars over the working life due to productivity losses. However, a reduction in high blood pressure of 25% resulted in 34 billion Australian dollars being saved. So why then are we interested in lifestyle modification for the prevention and management of hypertension? Well, despite this significant health and economic burden, we know that the condition is still poorly managed. In fact, as we've heard over the last few days, adherence to blood pressure lowering medication is poor. 46% of individuals receiving treatment for high blood pressure do not actually have controlled blood pressure. And 90% of people have essential hypertension, meaning that there's no single cause for their hypertension and it may be linked to a number of modifiable lifestyle factors. So these modifiable lifestyle factors include obesity, poor diet, physical inactivity, smoking, and excess alcohol consumption, among other factors. However, in the interest of time today, I won't discuss those. So if we can potentially manage these modifiable lifestyle factors, we can potentially prevent a large proportion of hypertension. And importantly, this can be done relatively easily and is inexpensive. So I'm now going to just provide you with some information regarding the relationships between these lifestyle factors and hypertension and how we can modify these in terms of and how it can be beneficial for preventing hypertension, and then also provide you with some recommendations for how to work with these lifestyle factors once someone does have hypertension. So a 10% weight gain is associated with 6 millimeters mercury increase in systolic blood pressure. And someone who has a BMI within the overweight category of 26 to 28 kilograms per metre squared, as compared to someone who's got a normal BMI, has an elevation in risk of hypertension of 180%. Perhaps quite alarmingly, we're seeing more and more children and adolescents who are in this overweight or obese category. And in fact, in Australia, 25% of children aged 5 to 14 years are overweight or obese. And we know that elevated body mass index at age 10 is associated with an elevated risk of hypertension in adulthood. So this is quite concerning given the growing numbers of children in this overweight and obese category, both in Australia and worldwide. However, controlling obesity may eliminate 48% of hypertensive cases in Caucasians. So if we can actually get our patients to lose weight, do we see a reduction in blood pressure? And this systematic review and meta-analysis showed that 5 kilograms of weight loss resulted in approximately 4 millimeters mercury reduction in systolic blood pressure and 3 millimeters of mercury reduction in diastolic blood pressure. And we know that a reduction in systolic blood pressure of 10 millimetres of mercury is related to 13% risk reduction in all-cause mortality. So if we can get our patients to lose 10 kilos, then we can potentially reduce risk of mortality by 13%. 5 kilogram weight loss is also associated with 15% reduction in incidence of hypertension over 12 to 15 years follow-up. And a 5% weight loss is associated with a reduction in a host of other mechanisms that we've heard about over the last couple of days that contribute to risk of hypertension. So then what about poor diet and risk of hypertension? And I'm just going to focus on sodium and potassium here as just in the interest of time. So we know that processed foods are high in sodium and low in potassium. In fact, 75% of sodium consumed comes from processed foods. In Australia, the recommended intake of salt is 6 grams per day, which is equivalent to 1 teaspoon. However, men are consuming 10 grams per day and women are consuming 7 grams per day. And interestingly, consuming 6 grams per day of salt is related to a 0.4 millimetre of mercury increase in blood pressure across the year. So if we can keep this lower than 6 grams, then we can potentially minimise the age-induced elevation in blood pressure. So what about potassium? Well, a diet high in potassium is related to reduced or lower blood pressure, prevalence of hypertension and stroke. And on the other hand, a diet low in potassium but coupled with usual sodium intake results in sodium retention and also a significant elevation in systolic and diastolic blood pressure over just 10 days. So then if we modify the diet, do we actually see any changes in blood pressure? And the answer to that is yes, we do. So this study, the DASH sodium trial, showed that over 14 weeks in 412 participants who were randomised to either the normal American diet or the DASH diet, which is high in fruit and veggies and low-fat dairy. And then these two groups were both put on lower sodium diets. And these researchers saw that those people who were still consuming the normal American diet but reduced their sodium intake from 8 grams to 4 grams per day had, on average, a reduction in systolic blood pressure of 8 millimetres of mercury and 4 millimetres of mercury in diastolic blood pressure. And that's shown here in these black squares. So then what about for potassium? A diet rich in fruit and veggies is related to a reduction in systolic blood pressure of 7 millimetres of mercury across an 8-week intervention, as shown in this figure here, and a reduction in diastolic blood pressure of 3 millimetres of mercury. Interestingly, in hypertensive subjects, if they increase their consumption of potassium, we actually see that across the course of 1 year, 85% of those patients required less than half of the medication that they were administered earlier, and 38% of those patients required no medication at all, simply by increasing the amount of potassium they were consuming. So next to physical inactivity, we know that physical inactivity is responsible for 5 to 13% of cases of hypertension, and that each hour spent sitting or sedentary per day is related to a 2% increased risk of hypertension. Importantly, this work highlighted the importance of regular and continued physical activity across the life course. So shown in this figure here, those males who were active at age 23 but not active at age 45 had a similar risk of hypertension compared to those men who were not active at 23 and not active at 45. So this highlights that even if we're active at a young age, we have to maintain that level of physical activity across the life course in order for this to have beneficial effects on blood pressure. And then this systematic review and meta-analysis showed that those people who engaged in higher amounts of moderate intensity activity and also high intensity activity had a lower risk of hypertension. And finally, for physical activity, this work here actually was comparing the benefits of exercise compared to blood pressure lowering medication, and showed that actually for those people, hypertensive subjects, that exercise was just as beneficial compared to medication for lowering systolic blood pressure. Okay, so for smoking, we know that this has been a little bit controversial, I guess, because in the clinic, smokers can be seen to have the same blood pressure compared to non-smokers, or even may have lower blood pressure compared to non-smokers. However, 24-hour ambulatory blood pressure monitoring data has shown that smokers have elevated blood pressure, daytime blood pressure, compared to non-smokers, despite having the same clinic blood pressure. Smoking results in an acute rise in systolic blood pressure of approximately 3 to 12 millimeters of mercury for 20 to 30 minutes post-smoking. And importantly, brief exposure to passive smoking results in about 80 to 90% of the same risk of chronic smoking. So this is potentially important for children who are exposed to passive smoking, who are potentially at the same risk as if they were smoking themselves. So if we can then get our patients to stop smoking, does this actually have any effect on blood pressure? This study showed that it does. So in this study, after 6 weeks of smoking cessation, there was a reduction in systolic blood pressure, despite this group putting on a small amount of weight. And over 1 year, there's also been, this study also showed that a reduction in smoking, or stopping smoking, resulted in a reduction in central blood pressure and also in arterial stiffness. Okay, so finally for alcohol consumption, and I thought it was quite interesting that the first observation between the relationship between alcohol consumption and risk of hypertension was observed in 1915 in French soldiers, where the medics actually noticed a high prevalence of hypertension within these soldiers and realised that it was probably due to the large amounts of wine that they were drinking, because they were consuming about 2 litres of wine a day each. So we know that chronic alcohol consumption is related to an increased incidence of hypertension. However, acutely, alcohol consumption causes a drop in blood pressure, and this is likely due to peripheral vasodilation. Chronic alcohol consumption, so more than 2 drinks per day, equals a dose-dependent rise in blood pressure. So then what about if we reduce alcohol consumption? Does this actually have any effect on blood pressure? And this systematic review and meta-analysis of 36 studies showed that for those people who are consuming 2 or fewer drinks per day, actually reducing alcohol consumption doesn't actually have much of an effect on blood pressure. However, for those people consuming 3 drinks per day, there is a slight reduction in blood pressure. Those people who are drinking 4 to 5 drinks per day, there's an even greater reduction. And for those people consuming 6 drinks per day, there's a greater reduction still in blood pressure. Okay, so I now just want to provide you with a few recommendations in terms of how to manage these lifestyle factors in someone who's actually got overt hypertension. And these recommendations come from the Australian National Heart Foundation guidelines for management of hypertension in adults. So these guidelines recommend that people with hypertension can engage in various amounts of physical activity. And this was detailed a little bit further in a recent position paper by Exercise and Sports Science Australia, which showed that people with hypertension can engage in moderate or vigorous or high intensity exercise for various durations and on various frequencies throughout the week. This position paper also recommended that patients with hypertension engage in resistance activity on 2 or more times per week. And recently, given the current climate with the COVID pandemic and the fact that a lot of us have had our exercise routines interrupted lately, we at the Baker Institute developed a number of different home exercise programs that can be done in the comfort of your own home without the need for any expensive gym equipment. So these are available on our website to download, and I would encourage you to have a go yourself or to distribute these among your patients. And if you'd like to read more about it, we recently wrote about this in the conversation. So in terms of weight management, these guidelines recommend that we encourage our patients to come down into this normal weight category. In terms of diet, they recommend that hypertensive patients should be consuming low salt diets and diets high in potassium. So in order to get enough potassium into your diet, you would need to consume 10 bananas per day. But luckily there's other fruit and veggies that are high in potassium also, so it doesn't have to all be bananas. In terms of smoking, these recommendations encourage our patients to stop smoking. And in terms of alcohol consumption, it's recommended that both men and women can consume 2 standard drinks per day. So a standard drink is 1 beer or 1 glass of wine, for example. So in conclusion, hypertension poses a significant global health and economic burden. And 90% of hypertensive cases have no single cause and may be linked to modifiable lifestyle factors. Adherence to blood pressure lowering medication is poor. However, modifying behaviour through weight loss, improved diet, physical activity, smoking cessation and reducing alcohol consumption could prevent a large proportion of elevated blood pressure. So thank you very much.
Thank you so much, Rachel. That was a wonderful talk and very insightful. I'd like to open the floor for questions. There's already one that's already in the chat. And the question comes from Nural Azian, and their question is, how about low-income populations in their diet? They tend to consume more processed foods that is cheap. Vegetables and fruits can be expensive to afford. So do you have any comments on that?
Yes, that's quite an unfortunate problem, I guess. I think that there can be a lot of foods, fruit and vegetables, legumes, for example, can be quite cheap. So lentils, chickpeas, things like this, which are high in fibre, and we know this has beneficial effects for blood pressure as well. So I would really try to encourage people to consume unprocessed foods as much as possible and try to cook things from scratch. So we know that a lot of salt, for example, comes in those processed foods. So if we can try to cook things from scratch from the raw vegetables using legumes, for example, then we can potentially minimise the amount of sodium that's in the diet.
Fantastic. We've got another question from participant M. Vale, and they're asking, isn't adherence to lifestyle measures worse than for medication?
That's a good question. I guess so, because we're seeing more and more people with hypertension and obesity, which we could potentially prevent if people were adhering to this lifestyle advice. However, I believe through patients I speak to that a lot of them don't want to be taking medication and would like to be, be able to manage their lifestyle rather than being prescribed medication. So I think if we can encourage people to manage their lifestyle earlier on before they reach the point where they require medication, then this is potentially a route to go down so that we can prevent them from actually having to take the medication in the long run.
Yeah, fantastic. And from Grant Drummond, we've got, is the acute change in blood pressure with smoking a direct effect of nicotine? Oh,
that's a good question. I actually don't know the answer to that. Sorry, Grant. It's not my area of expertise, but I can find out for you and let you know.
And I'd like to follow up with the smoking question. What about smoking during pregnancy, and does that increase the blood pressure in the offspring?
Again, that's a great question. I'm not aware of the literature around that. to be honest, I think, obviously we know the risks associated with smoking, so I wouldn't be recommending it in the first place, let alone if someone is pregnant. I think that potentially this can be quite harmful to the offspring.
Yeah, fantastic. I might just leave it there for the interest of time. Thank you so much, Rachel. That was a wonderful presentation. And that concludes our presentations for today. I'd like to now move on to announcing the winners of the student and ECR Blitz presentations. So if you could just give me a moment while I share my screen with you. Can everyone see my screen?
Yes.
Fantastic. So this is the awards session for the students and ECR Blitz presentations. And we are proudly supported by Servier, so thank you so much to them. And obviously, thank you to the High Blood Pressure Council of Australia as well. So the winner for the Blitz student presentation is Renata Libanato. So congratulations to her. And the winner for the ECR Blitz presentation is Neve Chapman. So congratulations to both of you. We'll be in touch with you shortly to collect your prizes of $100. So congratulations again. And that will conclude the presentation.